Welcome. My name is Dr. Lanty Jorenby. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 2 of a 3-part CME podcast series on best practices in opiate use disorder, optimizing long-term outcomes in patients with opiate use disorder, or OUD. Today's episode is titled Helping Your Patients Over the Detox Hurdle, Strategies for Successful Outcomes. I am the Chief Medical Officer at Lakeview Health in Jacksonville, Florida. Our learning objective today is essentially to implement best practices in managing detoxification in patients transitioning to MAT from opiate dependence. Our learning objective is really to determine what the best practices are and to help people maintain in treatment. So just to kind of review the opiate epidemic by the numbers, and these are 2016 to 2017 data. As you can see, these are pretty striking statistics. We see about 130 people die every day from an opiate-related drug overdose. There's 11.4 million people who have misused prescription opiates, almost 43,000 people who have died from overdosing on opiates, and about 2.1 million people that have an actual opiate use disorder that's been diagnosed. We know that about 886,000 people are using heroin, whereas we see 81,000 that are using it for the first time. And about 19,000 deaths can be attributed to overdoses on synthetic opiates other than methadone. And these could be fentanyl, which is taking first place as far as what's now a cause of overdose in America. And then 15,000 deaths have been attributed to overdosing on heroin. And as I mentioned, these are statistics from 2017 and 2016 as measured by the National Survey on Drug Abuse and Health and the National Vital Statistics measurements. I think it's helpful for us to review that there is a specific road to abstinence. There's often the fantasy of what looks like abstinence and then really the reality. And many people get to that abstinence phase after multiple tries. So if you take a look at this graphic, you can see that it demonstrates that there is, on the fantasy side, a clear path to getting clean and staying clean. Whereas on the reality side, we're seeing things that are quite difficult to surmount. People are really struggling, especially if they end up relapsing. That can lead back to a much lower level of recovery initially. And so that begins again that hard climb up. There is a lot of other complexities that go into this. And as you can see, detox generally should last about 1 to 2 weeks. But we know as physicians and clinicians that detox often, at least symptom-wise, there can be residual problems even several weeks or even months out. Early abstinence often is still an uncomfortable place for people to be, not just with cravings, but with also that prolonged withdrawal that can happen. And patients do have a measure of control over this, but we're also hoping that their brain is rewiring as they go through these episodes, whether it be early abstinence or late abstinence. It does take time for the reward system to improve. There are patient perspectives on opiate use disorder, and it's important to consider perception. Patients and their families often have this belief system that detox is treatment or it's all that one might need, whereas it's really a very small part of recovery. And in fact, most people that I treat initially think all they need is detox. And we now know that that is not necessarily the case, that the brain takes time to rewire, to reset, and it's going to be a much more persistent period beyond detox. That's how we get into the period of what fantasy is and what reality is. This slide just kind of highlights different perceptions or perspectives on opiate withdrawal. These are drawn from actual patients that have gone through this. Someone has mentioned that as their brain experiences life without prescription opiates, they really thought that their life was over, that they might die. But they found that the symptoms of withdrawal didn't kill them. Someone else mentions that always with withdrawals, they drove them back to opiates. And that's often what we'll see is that people relapse because of this discomfort that they have with withdrawal. Opiate use drives daily activities, and often people would feel like they couldn't get things done during the day if they were what we call drug sick or dope sick, and that often leads to relapse. For the addict mind, anxiety also is part of withdrawal, and that's commonly what I see in my practice here at Lakeview, is that anxiety is a very big factor for people. Their mind is telling them that their body needs drugs to manage the anxiety. And often what's happening too is that you have a reward system of the brain that's been hijacked by drugs. And that mind or that brain is telling that person they need drugs to survive. And others have said without opiates, they seem useless, or they feel useless, worthless, or pathetic. These are pretty difficult perspectives to understand and experience. I thought we could discuss a little bit about typical withdrawal characteristics of various opiates. As you can see on this slide, we have several common opiates that people come in with withdrawal for. Heroin is the top one, and often that is a half-life of about 2 to 6 minutes. And withdrawal begins fairly quickly and within 6 hours. And typically it's a length of duration of withdrawal, that acute withdrawal, about 8 to 10 days. Methadone is a much longer half-life. We're looking at 150 hours with a mean of a 35-hour. Most people start to go into withdrawal within 2 to 3 days. And this is a much longer withdrawal as well. It's 10 to 14 days. And really it goes back to the fact that methadone is a very long-acting medication. Buprenorphine, the mean average is about 37 hours for a half-life. Withdrawal happens a little bit faster, so we're looking at about 6 to 24 hours. And these symptoms of withdrawal tend to be milder, and they tend to be a little bit shorter than what we see with methadone. We're also seeing morphine withdrawal within about a short period, about 7 hours on average as far as half-life. The onset of withdrawal starts within about 8 to 12 hours, and it lasts about 7 to 10 days. And then if you look at oxycodone, hydrocodone, those two actually have a similar pattern of half-life. Hydrocodone does have a longer onset to withdrawal. And fentanyl, as I mentioned, is a synthetic opiate which has taken over as one of the #1 drugs that people are overdosing on, and commonly found now mixed with heroin on the street. That half-life is about 11 to 36 hours. The onset of withdrawal is still kind of questionable, and this may vary because of the potency that's out there and the different types of fentanyl now. You have acetyl fentanyl, carfentanil, so this is a difficult thing to measure. And we're seeing typical withdrawal last about 5 days. We know that as far as opiate use, we're seeing a lot of people obtaining illicit drugs on the street. Heroin is overtaken prescription medications now as #1 abusable opiate. I think this has been because of what we've seen across the nation with eliminating easy access to opiates, prescription opiates, through databases statewide, as well as tracking doctors who might be prescribing. So now that we see more heroin, it is a much more difficult thing to measure, especially as you see with fentanyl. Abrupt discontinuation of opiates really can cause some really serious and uncomfortable with opiate symptoms, opiate withdrawal symptoms. We're often looking to manage these in an inpatient setting, although outpatient settings are not completely unheard of. Methadone and buprenorphine, well known in the field as bupe. These are 2 medications that are FDA approved for use in treating opiate withdrawal. Morphine is typically used to treat infants who have neonatal abstinence syndrome. And pharmacists can also play a pretty big role identifying appropriate use of opiates in an outpatient setting. So if we look at what opiate withdrawal syndrome is, these are typical and very common symptoms or characteristics. And as you can see, we've defined withdrawal. It occurs when a person has developed tolerance and dependence, and that is a physical tolerance and dependence to opiates. Hence, when we abruptly stop opiates, people develop those symptoms that we have here: nausea, chills, sweats, rapid heart rate, muscle cramps, diarrhea. They often, 99% of people that I treat have insomnia, Depression, dysphoria, anxiety, and restlessness are very common as well. And they can vary in how they present. We also see that sometimes people have all of these in a very acute setting. Most of the time, people are telling me they feel like they have the flu, a very bad case. We know that the Centers for Disease Control has recently described our opiate use and resultant deaths or overdoses as an epidemic. And in treating this disease with medication, it requires skill and it requires time that most primary care docs don't really have the luxury of. We want to make certain that people are treated optimally because this will reduce the risk of relapse. It's important to consider that there are unethical practices that might happen at some point, and we want to make sure that there's really clear protocols. Access to good treatment is fairly restricted or has been restricted because there are few physicians that either have the time or the ability to use prescriptions such as buprenorphine or methadone to help people into recovery. There are practice guidelines that are available that have been developed, especially with buprenorphine protocols, in order to give people guidance on how to take someone through a detox and get them onto what we call MAT therapy or medication-assisted therapy. There are some guidelines that have to be followed as far as special populations such as pregnant women, people that have co-occurring disorders, psychiatric disorders, mood disorders, adolescents, people that have pain, individuals that are involved with the criminal justice system. These are all special populations that have to have a specific approach. So as we consider opiate withdrawal, and we know that those symptoms we highlighted earlier are very common, it's also important to think about how changes in brain chemistry occur and how they can trigger opiate withdrawal symptoms. So a normal brain, as you can see, a functioning, healthy brain is not going to have any opiate exposure of sorts. Norepinephrine levels are fairly stable. When we have opiate use, the brain changes and those norepinephrine levels actually go down. And this is often what happens when people become dependent. With continued opiate use, the norepinephrine levels tend to modulate a little. But when people go into withdrawal, this is where you have a fairly unstable norepinephrine level. And norepinephrine, I'm picking on that particular chemical because that's the chemical that really has a significant effect on withdrawal symptoms. The changes in autonomic nervous system, the discomfort physically, that is often driven by norepinephrine. And this can last a week or longer, as we saw with those other drugs, dependent on the half-life, dependent on the initial onset. This can last up to even 2 weeks. The National Institute of Drug Abuse and Dr. Volkow, Nora Volkow, have shown opiate effects in the brain in the reward system. And there are specific opiate receptors, mu, delta, and kappa, that are all activated with opiate use. The mu receptors are often involved with rewarding aspects of opiates, and these are found in that reward center, the nucleus accumbens, the amygdala, the ventral tegmental area. Kappa receptors are involved with the nucleus accumbens, and they can trigger that dysphoria that people experience when they go into withdrawal. And that dysphoria often induces a relapse because people don't want to feel bad and they know what helps them feel good. So that psychological effect with the kappa receptors is pretty critical when we look at opiate withdrawal. And we also know that there are alpha-2 adrenergic agonists, certain medications that can decrease the release of norepinephrine. As you recall with this particular scan, norepinephrine is a critical chemical in the brain that contributes to that opiate withdrawal. We will discuss those medications in a moment, but these are medications that basically inhibit or decrease norepinephrine release. So this is a slide that highlights how we assess opiate withdrawal syndrome. As you can see, there's a couple of different scales that can be used. The COWS, or Clinical Opiate Withdrawal Scale, is the most common one. It can be administered by a nurse, a physician. You can see that there's a short number of questions, about 11. It takes only about 2 minutes. It can be done in an inpatient or outpatient setting. It's a very flexible scale. And it assesses how severe people's symptoms are. And it's a critical piece of information when one is making a decision about medication treatment. There's also what's called the short opiate withdrawal scale, or SOWS, and it's patient administered. And it's about 10 questions, takes less than a minute or so to complete, and also inpatient or outpatient scale. And commonly, the most popular one, or the most useful one in an inpatient setting, is the COWS. We commonly use the COWS in the outpatient setting too. And both of these give us a general understanding of how severe these symptoms are for people. And based, as I said, on those scores, we would make a recommendation about medication to help people control opiate withdrawal syndrome. As you can see, the number one medication here listed, but it's not always the number one that we use, but this one is called clonidine. And clonidine, along with that second one, lofexidine, are both those alpha-2 adrenergic agonists. And they're helpful in modulating that norepinephrine level. With clonidine, a typical dose would be 0.1 milligram, 0.1 milligram, 4 times a day as needed for restlessness and anxiety. You definitely want to consider holding if your blood pressure is below 90/60 or a pulse of less than 50, because this is an antihypertensive medication. But for my purposes in my clinical practice, I've seen clonidine be very helpful with people who have that restlessness, that anxiety. And often you do not necessarily need to wait until they're severely uncomfortable or even moderately uncomfortable to start it. You can start it within the first few days or hours even. Lofexidine is one of the FDA-approved medications for opiate withdrawal, and in fact has been just approved within the last few years. We know that it is also not an opiate agonist. Like clonidine, it's an alpha-2 adrenergic agonist. And it is something, again, that's modulating that norepinephrine. And typically with dosing, you're using 3 0.18 milligram tablets about 4 times a day. And this can go as long as 7 days. There may be the need to continue treatment beyond the 7 days, so up to 14. And the benefit with this particular medication, unlike with clonidine, is there's less effect on the blood pressure. So there's less need to be careful in monitoring and holding the medication if necessary. Gradual dose reduction needs to happen every 2 to 4 days. The last 2 medications, as you see, buprenorphine and methadone, are opiate agonists. Now, buprenorphine is a partial mu opiate agonist, meaning it acts on that mu receptor. And it's a once daily, although we use it more frequently with detox, sublingual medication. We generally want people to be in moderate withdrawal before we prescribe this, because higher doses, if people aren't in enough withdrawal, can precipitate withdrawal. Remember, this is a partial agonist. It has a built-in mechanism that helps with preventing overdoses, because it also has that antagonist quality at the opiate receptor, the mu receptor. And high doses above 4 milligrams, again, we have to be careful about precipitating withdrawal. Buprenorphine can be very effective with opiate withdrawal with your other symptoms. If we look at clonidine and lofexidine, these are helpful for some of the anxiety, the restlessness. But for buprenorphine, we see some benefits with mood, dysphoria. Much of it can help with the GI and the cramping. It's a very helpful medication. Methadone, which is a full mu opioid agonist, this one is often used single doses, 20 to 30 milligrams. It can be involved with protracted withdrawal symptoms. It is something that you have to monitor carefully because there is a risk with overdose. That is a full opiate agonist, not a partial, like with buprenorphine. It's important to note that with buprenorphine and clonidine, these are not FDA approved, although they are commonly used for opiate withdrawal syndrome. They're not FDA approved for opiate withdrawal syndrome. This is a bit busy of a study, but I think it's important just to recognize it looks at what we call the efficacy of lofexidine. And as you can see, they used the short opiate withdrawal scale to monitor people's symptoms. Again, that's more of the patient-administered scale. And you can see with the colored lines, which are pink and blue, those are using specific doses of lofexidine. And then the very top one, that's the broken line, that one is without any medication. It's a placebo, excuse me. And people often, when you're looking at this, they have lower short opiate withdrawal symptoms and low COWS withdrawal symptoms with both lofexidine over your placebo. And this tells us that it's a very effective opiate withdrawal medication. And it's a little bit busy of a scale as well, but this is highlighting the effectiveness of buprenorphine versus clonidine. Again, we're seeing benefits with buprenorphine for managing opiate withdrawal. Clonidine often is something that here at Lakeview we use together with buprenorphine, giving people that comfort as far as the anxiety and the restlessness, and the buprenorphine is helping with that activated mu receptor. This is looking at buprenorphine use versus methadone use. And we're again seeing a pretty good equal efficacy. There's really not a lot of difference between the two as far as completing withdrawal. They're equally effective. So if we were to highlight current strategies for withdrawal management, as you can see here, I have a few key points. We're talking about tapering doses of opiate agonists such as buprenorphine, and that's commonly what we'll start with is when people are in moderate withdrawal. We will start their buprenorphine, get them to a level that keeps them comfortable, and taper over a period of a few days to weeks. We're also using in conjunction and commonly that alpha-2 adrenergic agonist, whether that's lofexidine or clonidine. Now, there is another box on this slide that highlights naltrexone and naloxone. Naltrexone is a medication that's commonly used in what we call MAT therapy, medication-assisted treatment. And MAT therapy is something that helps people maintain in recovery beyond detox. Naltrexone is commonly used in conjunction with other medications if they have persistent withdrawal, and I've had those medicines listed, the gabapentin again, and clonidine. And there are some unapproved protocols out there using naltrexone as a method to get someone from buprenorphine into a long-term naltrexone use for recovery. Let me explain that a little bit. So we're talking about a couple of different things. One, we're talking about opiate withdrawal, but remember again, managing withdrawal and detox is different from treatment. Naltrexone falls into the treatment category. Now, naloxone is a common drug that most of us are familiar as Narcan. Narcan is that emergency reversal for opiate overdose. It's the opiate overdose drug that brings people back to life. It's commonly in the news, and you often know that paramedics who are responding, first responders, are commonly using it. There have been examples of people who are on planes that have fallen into an overdose, and there's no Narcan available. And so it's one of these medications that can save lives, but again, thinking about how it works, it's not treatment. So often, if we're thinking about naloxone, it's an emergency medication that saves a life from an overdose, but it doesn't necessarily get them the treatment. So the treatment phase is the next part. And realistically, when we look at all of these medications and what we want to use, patient selection really does involve some key things. How do we decide who might be appropriate for buprenorphine versus who might be appropriate simply for clonidine? Really determined by how people are motivated, the support system and the social structure that they have in an outpatient setting, their treatment setting in general. So if you're treating someone in an inpatient setting, you have more flexibility. You have the ability to monitor them closely, and there's nursing support. But if you're working with someone in an outpatient setting, you often want to use medications that have more safety protocols in mind, especially if someone's taking medications home. And with buprenorphine being a partial agonist, partial antagonist, you have more built-in safety mechanism with that. Thinking about buprenorphine, not just for detox, but also induction into maintenance therapy. And again, that is what we call MAT. Maintenance therapy keeps people in recovery long-term. And this can look like several months to years. People maintain on something like buprenorphine or even methadone, and they're able to recover their lives. They keep a job. They have a stable family. And so when we think about buprenorphine, it's not only something we use for detox, but if people are appropriate, and that again comes back to patient selection, then they may benefit from induction onto maintenance therapy. One of the approaches that I take when we're evaluating someone for maintenance therapy, we're looking at their full history, we're getting a physical exam, we're evaluating what other substances they might be taking, we're doing the cows. Of course, the cows will tell us how much withdrawal they may be in at that time. We start a dose of buprenorphine. It can be up to 4 or even 6 or 8 milligrams, dependent on what they're using, how uncomfortable they are, and their symptoms. And then if we're looking at keeping them on maintenance therapy, so let's say they go through withdrawal 3 or 4 days, we get them comfortable, and then they are appropriate, and that is a team decision. If we decide that they're appropriate for maintenance therapy, and again, think about patient selection, their social support, their medical history, what they choose, because patients often have a very distinct opinion about what they want to continue on. But let's say this patient is appropriate. Typical doses that are stabilizing for people with opiate use disorder include up to 16 milligrams a day. And they also will require, if they decide to stay on that medication, outgoing patient therapy. So that can include 12-step groups, smart recovery. It includes outpatient individual therapy, psychiatric follow-up if appropriate, given if they have a co-occurring disorder such as a mood disorder or depression. So if we want to summarize with what we call SMART goals, and SMART goals are specific, measurable, attainable, relevant, and timely, SMART. We are, I'm really hopeful that this is concrete information that you can incorporate into your practice. You now have the information on how to utilize certain questionnaires such as the COWS and the short opiate withdrawal scale, the SOWS. We've also given you information on medications that are appropriate, whether they are, what types of areas of the brain they're going to work on, and some information on how to decide if someone is appropriate for ongoing maintenance therapy with something like buprenorphine or naltrexone. Finally, we are hopeful that implementing these evidence-based therapies will help your patients long-term in recovery. Thank you for joining us today for episode 2 of our 3-part CME podcast. To view additional episodes on the role of extended release MAT in relapse prevention, as well as best practices for applying extended release MAT in a real-world setting, please visit cmeoutfitters.com. You can also access the Opiate Education Hub, which is a premier source for opiate education and resources, including a diverse educational activities on opiate use disorder, animations of addiction pathways in the brain, over-the-counter pain resources, and tips and tools for patients, caregivers, and parents. Thank you so much for joining us today.